This presentation is a review of select anticoagulants and antiplatelet drugs. Be sure to review these drugs in your pharmacology text and other reliable resources, such as a drug reference book. So as a reminder, we've just discussed anticoagulants, which interfere with the coagulation cascade and target venous thrombi. Now we're moving to antiplatelet drugs, which work very differently. We're targeting platelet aggregation, the core of an arterial clot, and these drugs work by interfering with or blocking receptors on platelets. So beginning with aspirin, it's important to recognize that aspirin has a lot of roles. It's commonly used as an antiplatelet drug, but has a number of other benefits to be aware of. As an antiplatelet drug, it's used for patients with risk of ischemic stroke, not hemorrhagic stroke, or transient ischemic attacks. It's also used for that. Unstable or stable angina, patients with coronary stents. It's also used in an acute myocardial infarctions or even for patients with a history of an MI or risk of MI. So remember, aspirin or acetylsalicylic acid is a COX-1 and COX-2 inhibitor. So thinking back to COX-1 and COX-2, or cyclooxygenase 1 and 2, by inhibiting both of these enzymes, it creates two groups of actions associated with COX-1 and a group associated with COX-2. So you can see here, by inhibiting COX-1, we get that antiplatelet activity, and that's why it's called an antiplatelet drug. However, this is also an analgesic drug and an antipyretic and an anti-inflammatory. So just as a quick reminder, you can see the therapeutic effects of aspirin in green associated with inhibiting COX-1 and then COX-2, but you can also see the negative effects in red associated with inhibiting COX-1 and then COX-2. So one key aspect to remember about aspirin is that the action will occur on the platelet for the life of the platelet. It's irreversible. So in a sense, that platelet will not aggregate until it dies, and its lifespan is about 7 to 10 days. So therefore, aspirin must be stopped about a week before surgery. We can't reverse aspirin and uninhibit those platelets. We have to wait for those platelets to die, in a sense. So as the nurse, what do we need to think about? Well, along with monitoring for all of those signs of bleeding that we've already talked about, you can base a lot of what you do as the nurse off of what happens when we inhibit COX-1 and COX-2. So aspirin should not be given in a patient with a hemorrhagic stroke because we're going to already reduce platelet aggregation and cause risk for bleeding. Also, because we're already monitoring our patients for signs of bleeding and we see that inhibiting COX-1 can cause GI distress, we need to be very conscientious of a potential GI bleed. This risk is actually quite high in patients taking aspirin. So patients with active peptic ulcer disease should not receive aspirin. This is a contraindication. And additionally, you may remember that patients with nasal polyps and allergic rhinitis are often at risk for aspirin sensitivity or even salicylate toxicity. So additionally, research has shown that smoking can actually inhibit the antiplatelet activity of aspirin. So another thing to remember is that aspirin is a pregnancy category D drug. So that means that there's evidence that aspirin could pose a risk to the fetus, but in some extreme cases it could be used if the benefits outweigh the risks. But generally aspirin is avoided in pregnancy if at all possible. So our next antiplatelet drug is Clopidogrel or Plavix, and this is used for many of the antiplatelet reasons that aspirin is used, so to prevent stenosis of coronary stents, to prevent an MI or an ischemic stroke, and other arterial vascular events. So Clopidogrel blocks receptors on platelets, and thus it's going to prevent platelet aggregation. A similarity between aspirin and Clopidogrel is that both of these drugs inhibit platelet aggregation for the life of the platelet. This is also irreversible. As the nurse, we are again monitoring for all those signs of bleeding, and patients taking Clopidogrel may rarely develop what's called thrombotic thrombocytopenia purpura, or TTP. And this most typically will happen in the first 2 weeks, if it happens at all. It's quite rare. But in the first 2 weeks of taking Clopidogrel is when they see that it commonly happens for those patients that develop TTP. And the patient will present with hemolytic anemia, a low platelet count, kidney dysfunction, fevers, and even neurological disturbances. And TTP can be fatal, so it's really important to educate patients about this risk. And just a reminder, giving any antiplatelet drug with any other antiplatelet drug or anticoagulant will increase risk of bleeding. Now, additionally, proton pump inhibitors like omeprazole can actually inhibit the antiplatelet effects of clopidogrel. So you can see how this might get a little tricky. We're concerned about GI bleed with any antiplatelet drug and any anticoagulant. So we try to protect the stomach by giving a proton pump inhibitor. But now we may have protected the stomach, but the clopidogrel is not effective anymore, not as effective anymore. However, if a patient is at risk for a GI bleed, maybe they have peptic ulcer disease. Certain professional organizations have determined that this small reduction in the efficacy of clopidogrel is actually worth it to reduce the risk of GI bleed with a proton pump inhibitor. So let's look at a question. Which of the following is not true about aspirin? 1. Aspirin will inhibit platelet aggregation for the life of the platelet. 2. Aspirin should be stopped at least 24 hours prior to surgery. 3. Aspirin should be used with great caution in pregnant women. Or 4. Aspirin increases risk of GI bleed. Pause the presentation and consider your answer. The correct answer is 2. Aspirin should actually be stopped at least a week prior to surgery. We are referring to that lifespan of the platelet here. Let's look at a final question here. Which of the following is true about clopidogrel versus dabigatran? Both dabigatran and clopidogrel have irreversible actions. Dabigatran is an antiplatelet drug. Clopidogrel is an anticoagulant. Neither drug requires assessment of INR to determine efficacy of the drug. Clopidogrel may cause GI distress, dabigatran will not. Pause the presentation and consider your answer. The correct answer is 3. Neither of these drugs requires assessment of INR to see if the drug is actually working appropriately.